Hi there, my name is Nav Jesuraj, and this is my presentation on Disseminated Intravascular Coagulation, or DIC. Meet Jed, a 78-year-old male presenting to A&E with blood in his urine, black tarry feces, and bruising on his abdomen and lower back. 2 days earlier, he presented with back pain and was given a painkiller. I included his past medical history and drug history just in case you're interested. The back pain and excess bleeding made a haematologist suspect that this may be an aneurysm-related DIC. An aneurysm is a bulge in a blood vessel due to a weakness in the wall. A CTA was performed and they found the abdominal aortic aneurysm, or AAA, of 71 mm. To summarise, Jed had a bulge in his aorta causing back pain, then 2 days later presented with symptoms of DIC. To understand DIC, it will help to quickly recap normal physiology. When there's damage to a blood vessel, the body vasoconstricts to reduce blood flow. Platelets adhere to the damaged region, recruiting and activating other platelets to form a platelet plug. This process is primary hemostasis. Naturally, this is followed by secondary hemostasis, or the coagulation cascade, where clotting factors become activated to cleave each other in a particular sequence, with huge amplification. The final step activates fibrinogen into fibrin. This polymerizes and forms a mesh over the injury, thus forming a hard clot. As soon as this occurs, the body starts initiating mechanisms to break down the clot, to control size and ensure it dissolves once the vessel heals. This is called fibrinolysis. This releases fibrin degradation products that aid investigation in DIC. The body constantly balances these two mechanisms to maintain hemostasis. In DIC, clot formation outweighs fibrinolysis, leading to increased clotting. However, this paradoxically also leads to increased bleeding. Let me explain. Clotting blocks blood and therefore oxygen supply to important organs, causing ischemia. This leads to platelets and clotting factors getting used up, which causes bleeding. This is why DIC is also known as consumption coagulopathy. Many different conditions can cause DIC. Diagnosis requires at least one to be identified. Sepsis is the most common cause. Because DIC has such a wide range of causes, risk factors and epidemiology are very varied, and there is no predisposition for age, race, or sex. The commonality between these conditions is that they induce the release of procoagulants, tipping the scales towards clot formation. In aneurysm-related DIC, the pathophysiology is unclear. DIC has been shown to affect 2 to 4% of patients with AAA. Studies using radioisotope-labelled fibrinogen have shown that consumption coagulopathy occurs within the aneurysm. However, there are 3 subtypes of DIC: suppressed, balanced, or enhanced fibrinolytic, leading to many different clinical manifestations, ranging from localized thrombosis to diffuse, life-threatening bleeding. Aneurysm-related DIC is generally of the enhanced fibrinolysis subtype. Unfortunately, the reasons for this are still unclear. Anyway, back to Jed. As I previously said, diagnosis requires an underlying condition, and as shown on the CTA, Jed has a AAA. Jed's global coagulation tests came back as the following: decreased platelet count due to consumption coagulopathy, increased prothrombin time due to less clotting factors, increased fibrin degradation products from fibrinolysis as previously illustrated, and a decreased fibrinogen level. Other blood tests were performed to shed light on the subtype of DIC. Jed's coagulation and fibrinolysis activation markers were high, and consequently, alpha-2 plasmin inhibitor was significantly reduced. The cornerstone of DIC treatment is generally to first treat the underlying disease. In Jed's case, this would be surgical by aortic replacement or stent graft insertion. Studies disagree on the timing of surgery, and some even report that surgery can have adverse outcomes on the DIC status of the patient. When Jed heard this, he decided against surgery for the time being. Jed's platelet count and fibrinogen were low, and he had some significant bleeding. This indicated a platelet transfusion and a fresh frozen plasma infusion to increase levels of platelets and coagulation factors and inhibitors. After some diligent Googling, Jed found some serious potential side effects of these treatments. He wanted to know if they could happen to him. Fortunately, a medical student with a first-class Pharm BSc was on hand. He informed him that severe anaphylactic reactions occur less than once per 100,000 transfusions, and that acute lung injury can be avoided by using plasma from a male donor who has never been transfused before. The use of anticoagulants such as heparin and low molecular weight heparin are the most widely accepted agents in DIC. The antithrombotic effect of heparin is well correlated to the inhibition of factor Xa. This is helpful because it inhibits DIC's hypercoagulable component. However, for Jed, his presenting complaints were of moderately severe bleeding symptoms, not hypercoagulability. This hyperfibrinolytic clinical picture means that anticoagulants, if used at all, should be used carefully. In this case, unfractionated heparin would be chosen due to its quick reversibility. Therefore, antifibrinolytics must be co-administered to account for the hyperfibrinolytic component. The British Medical Journal, or BMJ, which is the leading clinical authority on treatment options, gives tranexamic acid, or TA, as an option. Its mechanism of action is that it binds to the 5-lysine site of plasminogen, blocking the binding of plasminogen to fibrin and its activation to plasmin. With no activation of plasmin, there is a reduction in fibrinolysis. This consequently will reduce the amount of bleeding. So why was TA included as an option in the BMJ? Well, the majority of their information came from a guideline, which was created in response to UK haematologists' requests. The writers consisted of a member of the British Committee of Standards in Haematology and 2 other recognised experts in the field. Their method of data collection was systematic Medline searches for English publications up to June 2007 using the following key terms. References from initial papers and guidelines were examined, however, the meeting abstracts were never published. After the guideline was created, it was reviewed by 40 UK haematologists and other established haematology boards. These guidelines could have been improved by having a more extensive list of Medline searches, being more transparent with their meeting abstracts, and it also may have been a little outdated because there are no papers accounted for after 2007. It is still, however, the most comprehensive and trustworthy guideline we have to date. This guideline stated that antifibrinolytic agents are generally not recommended and inhibition of the fibrinolytic system seems inappropriate. However, an exception may be made in rare cases where hyperfibrinolysis dominates the clinical picture. This exception applies to JED. The reason this guideline included TA is because of a double-blind case study from 1989. In this study, 12 patients with acute promyelocytic leukemia, or APL, were randomised either to TA or placebo for 6 days to see if it would reduce hemorrhage and transfusion requirements. They devised a scoring system to quantify the patient's bleeding symptoms daily. They found that the cumulative hemorrhagic score was 3 in the TA group compared with 42 in the control. Also, the overall units of packed red blood cells given in the TA group was 28 and 56 in the control. Furthermore, no thromboembolic complications were observed. This study could have been improved by involving more participants and having a longer treatment window to explore the long-term effects of TA. Overall, it was a good first step in this area of research. Another note, which isn't a criticism in itself, is that the study focused on APL rather than DIC, which is fine, but it begs the question, why is this the best evidence the BMJ can provide for the treatment of DIC? Well, the truth is they just have to hope that the underlying fibrinolytic mechanisms are similar enough that it will still work. There are no current high-quality studies investigating TA in DIC, and 1 year after the previous paper, the first-line treatment for APL changed to all-trans-retinoic acid, or ATRA, which could induce complete remission of APL. Unfortunately, TA didn't interact well with it and was scrapped from the management lineup. This was well demonstrated by a retrospective study by Brown et al. Of the 31 participants being treated for APL, 4 were given TA and ATRA in combination. All of them died. Of those given ATRA without TA, only 1 of 9 died. A striking feature of this study was that the post-mortems of those in the TA-ATRA group clearly implicated thrombosis in the microvasculature as the cause of death. Although this study was very small and had a scattered methodology, its point was abundantly clear: not to give TA and ATRA together. This meant no more studies using TA in APL were produced. So where does all this leave Jed? In terms of further treatment, he was given unfractionated heparin and TA for 6 days. But what happened next? I'd love to tell you the rest of Jed's story, but unfortunately I don't know how it ends. At the moment, DIC guidelines are exceptionally vague and poorly informed due to a colossal shortage of papers in this area. This was markedly displayed by the lack of evidence substantiating TA's presence on the BMJ's treatment algorithm. This leads to a lack of standardization in the management of these patients. Clearly, multi-center, randomized clinical trials must be published to further understand which therapies are best suited for each context, and to give people like Jed a fighting chance. Thank you for watching.